and it was for opioids. The problem at the time, for those of you, now I'm not going to date myself that much, I wasn't in medicine in the 80s, but I certainly was aware that heroin was a problem in 1986 as a young teen. But I do remember that, hearing stories, and I remember very distinctly heroin overdoses. Even in Manitoba it was a problem. And I mean, certainly there's still problems with heroin overdoses, but it was developed for heroin overdose, or for, in particular, heroin. The reason I mention that is because one has to remember the Finnegan score was not developed for all these other drugs. And remember that what you're withdrawing from, the withdrawal symptoms are the opposite of the drug, right? The effect of the drug. So why that's so important is you can't actually apply the Finnegan scoring to things like cocaine, methamphetamine. Now there's modified scoring for some of these things, but you shouldn't use the 8s and the 12s that you're going to hear about in a minute, because it's different different signs. So scores greater than or equal to 8 is significant, and this probably is not that important for you because you won't necessarily, like when you go to get a baby, chances are they're not going to have been doing Finnegan scoring. It'll be, you're going to pick the baby up and that'll be on the list of differential diagnoses for what's wrong with the baby. But just suffice to say, 3 scores 8 or above or 2 scores 12 or above mean that the baby needs some form of treatment. And as far as when you stop them, it's a little, like the guideline says, certainly after 3 days, if the scores are low, but I've stopped them earlier than that. If the score is really in an at-risk patient of 0, 1, and 2, I'll often just say, okay, they're just not. Now the drugs. So narcotics, I mentioned that, you know, Finnegan based it on heroin. It's common. You know, if a baby's been exposed, there's a very, very high likelihood they'll show some symptoms. As I mentioned, the presentation depends on the half-life of the drug, so methadone having a very long half-life of about 24 hours may not present until 96 to 48 hours, 4 days to 5 days. Ontario patients, you probably have noticed on transport, you keep hearing about the drug, well, 2 drugs, buprenorphine, and the other drug that you may hear about is Suboxone. So Suboxone is buprenorphine combined with naloxone. That's being used in Ontario. The government, you may wonder why it's not being used here. It's not being used here because our government doesn't cover it in pregnancy in terms of healthcare reimbursement, but medical plan reimbursement, but Ontario does, and it's much more expensive than methadone. Having said that, the withdrawal rates seem to be less with buprenorphine, so I think that we may see a shift at some point, because I think somebody's eventually going to do an analysis to say, you know, if we have less withdrawal and less admissions to hospital for withdrawal, will that compensate for the cost of covering this more expensive drug? But that's just in case you hear about Suboxone, because I know I can't remember who it was. There was a call from one of the transport nurses, and they said, "What is this?" You know, and it was Suboxone. So risk factors: the higher the dose, the more gets into the fat of the baby and the brain. The brain is full of fat, and so the higher the dose, within 24 hours of birth. You may hear me comment at some point, or heard somebody comment when a mom says she's been off a drug for the last 4 or 5 days, withdrawal may have occurred in utero. Okay, and so you might not see withdrawal because it already happened. The longer the use, so the longer the exposure, the more drug gets into the body and gets into the fat and is stored. And so, and then term delivery. I spoke about this a lot earlier. It's a very simple reason. The simple reason is, if you make it to term, you got a lot more fat, so the drug actually doesn't just come, because you might say, well, I don't get that, but if you're 28 weeks, the drug literally goes through the umbilical vein, there's nowhere for it to get deposited, and it just goes right back out the umbilical artery, so the baby doesn't process it. Non-opiate drugs, and this is an important point. You know, we talk about crack babies, and we talk about mums that are on SSRIs, but I mean SSRIs, while there is a defined withdrawal state from SSRIs, it's really is only symptomatic enough in about 5% of babies. About 1 in 20 babies will actually manifest enough symptoms to cause any problems. So If you see it in the history, the mom was on an SSRI, like sertraline, like Prozac, something like that, or fluoxetine, you might not, you shouldn't assume that if they're showing withdrawal symptoms, it's from that, because it's actually quite rare. But you may get, I have their cerebral malformations, porencephaly. So porencephaly is a big hole in the brain. And I remember seeing a case, it was a very sad case, of a mom who unknowingly was taking huge amounts of ephedrine in pregnancy. She was taking, that's the one where I got the pseudoephedrine from. This happened at St. B. It was a mom that showed up in fetal assessment with a huge cyst, basically part of the brain had liquefied. And the only medication she took in the whole pregnancy was this herbal remedy. And there was nothing on the box as to the active ingredient when she submitted it to us, but when we contacted the manufacturer, they acknowledged that it was ephedrine, and that's like amphetamine, it's a stimulant. And the ephedrine is a vasoconstrictor, so it was thought that that was probably the cause of her porencephaly. So you can certainly get vascular problems. And the biggest problem with all of this is, if they're using more than one drug, how do you know which drug caused, what symptom? So I have a few slides here on methamphetamines because I suspect it's going to come. We haven't really seen a lot of methamphetamine use here, except this is my one chance to teach you about drugs, so I thought I would teach you about this. Alberta, it's rampant. Lots of problems with methamphetamine, especially in northern Alberta. So I dealt a lot with that while I was out there, because it was so common. The clue, in case you don't know, is the teeth. Yeah, they get very yellow, orange, decayed teeth. Anyway, it's very easy and cheap to make. I don't know if you knew this, you can go to Walmart and make it. Yeah, like all the ingredients are right in your grocery aisle. And the truth is, it's awesome. Like, it's a great drug. I mean, I've not used it myself, but look what it does. I mean, who wouldn't want to be euphoric, all excited? Who wouldn't want to be more confident? And who wouldn't want to be awake, right? So, so it creates a state where you feel like you are Superman. You can do anything. And that in part is where some of these deaths have come from, is people jumping off buildings because they think they can fly and and they're indestructible and so forth. So it's a great drug in terms of what it says it can do, but unfortunately it's toxic. So effects on fetal growth. So this is one retrospective study. Again, they compared 134 to 160 non-users, and unfortunately, there was a lot of cigarette use and alcohol and marijuana use, because if they say marijuana is the gateway drug, I would say methamphetamine, if you're on that, it's a field day. It's like a buffet of drugs. You can have whatever you want, because if you cross that threshold of saying that's okay, chances are, if crystal meth is okay, virtually anything's okay. So what did they find? They found that the risk of SGA, so being small for gestational age, was significantly higher. Interestingly, if you were a smoker and using methamphetamine, you saw the incidence of growth restriction higher. Also interesting, I don't know if you look at head circumference. The head circumference, if you were smoking and you were using methamphetamine, was smaller than if you were not using. So the message there is, if you're going to use crystal meth, please don't smoke.
Right.
Now also, there is a dose exposure. So if you only use crystal meth in your first trimester, you're not really impacted to any great degree, even in the first and second, but your weight drops and your head circumference drops if you use it throughout pregnancy. So again, message is, try not to use crystal meth. But if you see a baby, but you might say, why is he teaching me this? Well, one, you might see it, and I suspect at some point it's going to get into this area. And the second reason is because it does cause a small head circumference. If you get that in the history, because remember I said, keep going back to where did we start? I said, don't have tunnel vision, right? When you see something like a small head circumference, don't just say, oh, we're on crystal meth, it's that. Or, oh, it must be a problem with a virus. if they had crystal meth or even cocaine probably in their history, that might be the cause as well. So it's important to think about these things.
So the teenage girls that we see that are teaching each other to smoke so that they deliver small babies, this is going to be next.
It could be. Like I said, we saw lots of it in Edmonton, lots. And in fact, I worked, I was the medical director of the level 2 hospital that was in the crystal meth hotbed of the city. And so it was just rampant. We saw tons and tons of it because, again, it's cheap. Imagine, if you don't have a lot of money and you have the option of buying cocaine or marijuana, which is expensive relative, or I can go and buy a packet of Sudafed and I can't remember the other ingredient, ammonia or something like that.
Ammonia and matchstick covers.
Right. Yeah, so
Probably makes she's got a lab.
yeah, so you can or you can go and spend $10 and make yourself a huge batch of crystal meth. What are you going to pick? Yeah. It's a do-it-yourself project.
Makes your house highly explosive though.
Yeah, it does. Yeah, it is a problem. Yeah. So withdrawal, somebody actually created a score of greater than or equal to 5 using the Finnegan scoring. The good news is only 4% require pharmacologic treatment. So this is an example where, like with narcotics, you tend not to see a lot of effect on the growth of the fetus, but you see significant withdrawal symptoms. With crystal meth, you see a lot of effect on the fetus, so it's teratogenic. It causes small growth, small head circumference, but you don't see it. About 1 in 25 will actually have withdrawal symptoms. So I guess it's important to mention because maybe you'll go up to Thompson somewhere in the north, they're using this. I think solvents are similar. Solvents are similar where they may cause toxic effects on the growth of the fetus, but they tend not to be associated with withdrawal. Now I included this just because I was very interested. I once had the pleasure of working with a very, very smart engineer who became a radiologist. And he was attending a lecture where I had this slide looking at 13 children with prenatal meth exposure, and it showed what these kids were like later on. So these kids were I think they were school age, if I'm not mistaken. And what it showed was that the putamen, the globus pallidus, and the hippocampus are very deep structures in the brain. And interestingly, this fellow had done MRI studies of rats exposed to methamphetamine, and lo and behold, it was the exact same 3 structures in the rat that were affected by methamphetamine. So, this ties in with, well, why is the head circumference smaller? Well, it's probably smaller because it's killing off areas of your brain. So that was just of interest because certainly you won't be seeing any school age. Well, and again, maybe you will. You may see some school age people. So differential diagnosis of withdrawal, and this is what, again, going back to the same thing over and over again, not having tunnel vision. Withdrawal can manifest, it could be anything. So hyperthyroidism. So hyperthyroidism makes you really jittery, flushed, right? Hypertensive. Intracranial hemorrhages can cause lethargy or irritability. Anoxia, clearly the child who has a very positive history for anoxia, HIE stage 2, is laying there and not moving, or seizing, could be drug withdrawal, but is more likely to be anoxia. Hypoglycemia is the big one. Please check a sugar. Don't assume just because there's a history that says this child is withdrawing or could withdraw. Often great to check a set of electrolytes, a calcium, a magnesium, and a sugar. I would say sugar is the most common thing that we forget to do. I know I forget to do it. Yeah, I often forget to check a sugar. But it's probably the most important thing to remember to do. Sepsis, absolutely can't forget that. Don't be led down the garden path. So remember, if the doc or the nurse in the nursing station says this child is withdrawing, don't go up there, and I can't say it enough, don't go up there and say, I'm going to pick up a child with withdrawal. I'm going to pick up a child with these symptoms. Figure it out when you get up there and determine whether or not you should actually do a septic workup. We recently saw a child admitted twice in NIC with hyperviscosity. So I had 2 partial exchange transfusions, was poorly perfused, had respiratory distress. Tachypnea is a sign for withdrawal. So knowing what the hematocrit is could be useful. Suggested workup. So again, we talked about hypothermia causing some similar symptoms. So rule out hypothermia, glucose. We talked about calcium phosphate, CBC. Why do I have check HIV and hepatitis serology? What would that have to do with withdrawal?
IV drug. Yeah.
Right, and that's just being comprehensive. So thinking beyond caring just for the symptoms. The same people that are likely to be using these drugs also have a higher risk that they have HIV or have hepatitis. And why is that important? Well, that's important because let's say mom is Hep B positive and you haven't looked at that. You have a window of time. We have to get that vaccine in within 12 hours of age. And so you can call down to me if I'm on the end of the line and say, bringing down a mom who's Hep B positive, they don't have the vaccine in the nursing station. Maybe they all do, I don't know. But they don't have it up here, they're out. Make sure we have the vaccine ready when the baby comes down, right? So you can benefit that way. Urine toxicology screen, I've done them. I don't do them often, but I've done them where I'm convinced mom's lying to me and the baby's not responding to treatment. So if she only says I was using codeine in pregnancy and I give the baby morphine, and then I give them another dose of morphine, and the baby's still not responding, usually then I lay the guilt trip. I've talked about the guilt trip before, and I say, you know, I'm really just trying to help your baby. And the line I use, and it's been a very successful line, I love it when I have a marijuana smoker, because it gives me an in. And I'm not trying to be funny, I actually say this. I'll say to them, you know, have you heard that sometimes people get their marijuana laced with some other thing? And they'll say, yes, I've heard that. And so I'll say, well, thank you for telling me that you were using marijuana. I'm really concerned that while you were high, somebody's either slipped you something or slipped something in the marijuana. I give them the out, so I absolve them of guilt, and I say, I think I would more effectively be able to treat your baby if I knew it was being given. Is it okay if I collect a urine screen? And they all say yes. Because clearly I'm not blaming them. I'm blaming somebody else for poisoning them. And so I find that's an effective way to get that done. So if you're up in wherever you are and mom's up there and she's not coming down, try that line. You know, and then see if the docs up there can collect the urine and then let us know. My colleagues though would say they would counter with, well, just give phenobarb if you don't know, and that's another way to do it. But I still think I actually like knowing what I'm dealing with. And the last is special tests. So if you thought the baby, so actually here's a good one. We've had 2 babies in the last month born to moms with Graves' disease, and so Graves' disease produces thyroid-stimulating antibodies that can cross the placenta and stimulate the baby and cause such things as jitteriness, fever, irritability that can be confused. So you wouldn't draw a T4, but you could certainly looking for Graves' disease in the mom. You know, very important to pass on to us. And then the last thing would be either an MRI, CT, head ultrasound, looking for a cause of bleeding if the baby, especially if the baby's not responding to treatment. So you keep giving morphine because you think it's all narcotic related or opioid related, and the baby doesn't respond. Non-pharmacologic treatment. I'm a big fan of this. And this is a little plug for the postpartum ward. We have had incredible success with getting the 3rd floor in women's to do all of these things. You know, keeping babies with moms, skin-to-skin care, low-level lighting, clustering care, not disturbing. About 50% of the babies that used to be admitted to IMCN for withdrawal, like for treatment, are staying up on the labor or up on the postpartum now without any treatment at all. They're going home about 5 to 7 days of age, so the postpartum wards are keeping them. But if we can do that, it helps. Now, the last point there, increased caloric intake. A lot of these kids wind up on 24 calorie an ounce formula or supplemented with powders to get up to 24 because of their symptoms, they burn and a lot of energy, and as they're burning energy, they get hungry. And hunger, when you're irritable, is not a good thing. So, for those of you who have also cared for them, seeing intakes of 250, 300 mils per kilo per day is not uncommon. These kids have voracious appetites.
What's that?
In the last few minutes, I think I'm almost done. Treatment management. If you're up there and you need to give a drug, I always start with morphine. You can give it Q2. Give morphine 0.1 milligrams per kilo Q2 until the symptoms are controlled. Granted, I don't expect you to stay in that hospital wherever you are, but you can certainly give the first drug, and on the way, if the baby's, let's say 2 hours have passed, the baby's still bouncing off the table, you can always give a second dose. And then we drop down to 0.05 per kilo Q4. It says Q4 to 6. I always like Q4, I think. Get them under control first and then start doing. Phenobarbital we certainly use, although there's been a slow but steady shift away from phenobarbital. Phenobarbital is a bad drug. I really don't like it. We know that it causes some injury to the brain in terms of killing off more cells. So I use it if I have to use it, but certainly if you are in the unit, you'll hear people ask for phenobarb for sedation, and I always try to find a different drug. Although I did throw the towel and give phenobarb once this past week, when there literally was nothing else to give. Diazepam, I've never used. I think in PICU you might use, for seizure control you use, no? You don't use that? What are you using these days?
Medaz and Ativan.
Yeah, but benzos, yeah. Yeah, but some sort of benzo is your first line, whereas phenobarb is our first line. Beware of this, narcosis. You can overdo it. So if you give too much morphine to treat, if you keep giving the opioid, eventually you can suppress respiration, you can make them obtunded. So if you have a baby that swings from looking like they're withdrawing to just being flat, you might want to ease off on the opioid. Okay, and yeah, they can become quite, I've seen this happen, where you go way too far, you keep overcalling the withdrawal, and eventually the drug catches up with them. And so so that's why it's so important to be prepared. Like I would say, it'll be so important to have the RT on the trip when you're going to get these kids, because you might say, well, it's just a withdrawal patient. But if you overshoot and the baby needs CPAP or intubation, you'll be happy to have two. Non-narcotics, I would say in all cases we use phenobarbital. This isn't really that important. We talked a lot about growth and development already. And then this is the last point here is just, not that you guys are going to be doing this, but I think we need to do this, my soapbox, we need to do a much better job in Manitoba of keeping children and families together. I don't think it's a surprise to anyone here, we have the highest apprehension rate in Canada, and I'm hoping that we can fix that.
So our last neuro talk, TBI, HIE, common, status epilepticus. When I did my neurocritical care fellowship, I got taught the best rule about seizures. He said, Greg, if you ever get called to bedside for seizures, take your time. Because we don't treat seizures unless they seize for more than 5 minutes. So if you take your time and you get there, the kid is seizing, you do something, and if not, then you leave the room. Status epilepticus is a little bit different because you're on a flight, and obviously there's concern. Typically the reason why you're going to be called is because a kid came into a referring center, was seizing, either got slammed a bunch of drugs and now they're not protecting their airway, or they continue to seize despite getting numerous boluses of midazolam and dilantin. I took a look at really the most recent up-to-date kind of assessment, and there's a number of them. This one is in 2006. There's a few that are later, but this is by far the most comprehensive. This one in 2012. And if you want to do some extra reading, those are pretty nice reviews. So we'll talk about definitions, what's causing the seizures, the diagnostic workup, and of course how we treat it, which is going to be quite important for you. It's interesting because depending on when you read your papers, the definition is kind of changing a little bit. The old one used to be greater than 30 minutes of a continuous seizure episode, or seizing, not returning back to baseline within that 30 minutes. But there's kind of a new proposal that's out there that says really this 30 minutes is kind of antiquated. Let's look at 5 minutes. Something lasting more than 5 minutes is considered status or not going back to baseline. And I think the reason why is, part of it is the pathophysiology that's happening here with the excitotoxicity, and the reality that the longer a seizure will progress, the more difficult it is going to be to stop. So, seizures, as you know, in the ICU, and I'm sure the NICU is the same, is that typically we don't like to treat with Ativan, lorazepam, unless they seize for 3 to 5 minutes. And one of the reasons why is most seizures burn out, and some of them that go longer than that typically don't, and that's often our trigger to treat. But the reason why this 30 minutes, as I said, perhaps is a little bit antiquated, is because there may be permanent injury, number one, and secondly, there might be resistance. So if we don't treat aggressively at the beginning, it's going to be more difficult and more difficult and more difficult to stop this cycle from happening. So what's really important, I find, semiology, you're going to hear this term happen or occur every so often. Semiology is what does the kid look like? And every time you're on the phone, everybody's going to say the same, tonic-clonic seizures. And most of the time, they're not tonic-clonic seizures, they're something else. And so get into the habit of asking what that seizure looks like. And why is that important? Because tonic-clonic seizures means something very definitive. And most often it isn't that, but more importantly, it's very important to get an idea about what that seizure looks like, particularly when it begins. Because what you're interested in is in focality. If I have a seizure like this, and the rest of my body is okay, that means focality. If I have tonic-clonic and my whole body is moving, I'm involving my whole brain. What you want to know is focality, because with focality, you go down a different algorithm as far as differential diagnoses. There's a trigger somewhere in that brain. If I drink enough beer, I'm going to get into a tonic-clonic seizure. I don't have a focal neurologic deficit. It's something global. If I have an acute bleed in my motor strip or something going on somewhere, that's completely different. So get into the habit in your history of getting an idea about the semiology, and when you're talking to medical control and when you're charting, it's not tonic-clonic, it is what does it really look like? How long is it? And importantly, from a transport perspective, is what is the underlying etiology? Is it trauma? Is it anoxia? Is it ischemia? Is it toxicology? So in this one, we'll talk about convulsive, non-convulsive, and refractory status epilepticus. So convulsive seizures typically include rhythmic jerking of the extremities. There's oftentimes mental status impairment, and there may be focal neurologic deficits, and sometimes it's in the post-ictal period. Ictal meaning the time that they're seizing, post-ictal is after that seizure has ended. So that's convulsive status epilepticus, and this is typically quite easy to pick up. And the rhythmic jerking, again, rhythmic jerking, it's not tonic-clonic, it could look like a lot of things, and sometimes that's the description. There's rhythmic jerking of all the extremities. Non-convulsive status epilepticus is a little bit more difficult to pick up, obviously, because its clinical correlate is not as strong. And in the last 10 years, this has become a very, very common discussion, and something that I am very aware of in the ICU with our TBI and our HIE patients. Typically what's happening is that the brain is seizing, but there isn't a strong clinical finding. Sometimes there's no clinical finding, sometimes there's very, very little. Sometimes the clinical finding is just a raise in the heart rate, for example, or maybe it's a real subtle eye twitch or something like that. And when you put them on EEG monitoring, the brain is on fire, and yet you don't see it. Now this is common with our TBI patients, it's common with ECMO patients, it's common with our HIE patients, but it's very, very difficult to detect at the best of times, never mind in the transport setting. And the interesting thing that can happen is you can have a convulsive seizure that progresses to a non-convulsive seizure where the brain activity is the same, but it loses its clinical correlate. And these are very difficult. Of course, you don't have EEG technology. Of course, you don't have the niceties of being able to do a lot of clinical follow-ups in your patients in the back of a helicopter or a plane. These are very, very difficult to detect, but keep this in mind. Kind of the last one we'll talk about is refractory status epilepticus. And these are the ones that are most concerning and the ones that often end up in the ICU. They don't respond to the standard treatment. You give them midazolam, you give them a phenobarb load, a dilantin load, and they're still seizing. And these are the concerning ones, because as I said, anything that goes over 5 minutes, definitely over 30 minutes, become more and more difficult to treat. And the question is, are these ones, do they have a sinister underlying etiology? Is it that they weren't treated aggressively enough at the beginning? These kids can be very, very difficult to manage.
If you had a patient that had an extremely prolonged postictal phase and
Yep.
altered, would you be suspicious of the non-convulsive?
Absolutely, absolutely, yes. And that's always difficult, this post-ictal phase, because these kids have been given a lot of drugs, they've had a seizure. Are they post-ictal? Is it iatrogenic from the drugs, or is it non-convulsive? And that's where we need the EEG and something that you won't have in transport. That's a very good question. When you're thinking about acute processes, you don't have to memorize this. I'm just throwing it up there in a sense that the differential is quite broad, but if you do a history, oftentimes you can elicit all of this. Metabolic disturbances for any kid that's seizing, as we'll talk about later, we're going to get a full extended lights if we can. That's going to be screaming if their K is sky high or very, very low, or they're hypoglycemic. Sepsis is going to be a story as well, in a sense that they may be febrile, they're going to be vasoplegic, they're going to have a wide pulse pressure. All of these here, you should be able to get, or a lot of them, from the history in your clinical exam, and superimposed on that is this seizure. And a lot of times when these kids show up to these referring centers and smaller centers, everybody's really excited about the seizures because it's obvious and it looks devastating, and they forget that there likely is something that's underlying everything. And then of course with our population, you don't see this so much in the NICU, is that we have a lot of acute on chronics, these kids with ongoing metabolic issues, abnormal brains of course, kids that have a very potent seizure history and for whatever reason it got triggered. But I would say that in most cases, you should be able to get a pretty good handle based on a history on why this kid is seizing. So the prognosis and kind of what happens. The more your brain seizes, we have excitotoxicity, as we talked about in our TBI talk, where you have glutamate release, you have calcium rushing in the cells, and what does calcium do? It imposes apoptosis, neuronal cell deaths, it inhibits protein synthesis, and all this together, what happens is you get damage. Sclerosis is kind of a healing process in the brain, when it heals, it scars or cell death to your cortex. That's where the seizures come from, the outer layer of the brain. Kind of, if you look at your brain as an orange, it's the peel, where the inside is the deep white. Most of your seizures come from the peel, that thin layer of cortex. But you get widespread damage in the brain. And why is that? We talked about this glutamine excitation, excitotoxicity, the calcium-mediated damage again with the glutamate. And these are some of the mechanisms that are responsible that we talked a little bit about in TBI. So now if you forget about the brain and what happens to the rest of the body when all of this happens, one of the things that you may see is hypotension. You may see hypoglycemia because you can imagine that your metabolic demands are sky high. You can get this thing called neurogenic pulmonary edema. I put question marks because we don't really know what to make of it. You end up intubating these kids and you find out that their compliance is very, very poor. You need high peak pressures in order to ventilate these kids. Sometimes worsening acidosis. Because your metabolic rate is sky high, you get hypothermic, and sometimes it leads to death. So, what's the big deal? Convulsive status epilepticus, we see a lot of it. How serious is it? Well, when we're looking at our numbers here, we're looking at mortality, about 29 to 21%. What in blue is our different studies that they're quoting. We're talking about a mortality rate that's up to 20% here for status epilepticus, so it's quite high. These are in adults. In kids, the mortality ranges from 3 to 11%, so 10% about. So 1 in 10 kids may not leave the ICU or may not leave the hospital. And a lot of the times the reason why they won't leave the hospital is because of the secondary effects that it causes as well. How about morbidity? Severe, again, this is in adults, cognitive or neurologic sequelae. So 20% of adults die, another 15% have significant sequelae. Significantly, a quarter of them decrease their functional status, so they may not be able to do what they did prior to going into the hospital. So this is a big deal. This isn't the histology of the left ovary. Like this is the big deal here, and it's something that we have to treat aggressively. Okay. Non-convulsive status epilepticus, an interest of mine as well. At hospital discharge, now all of a sudden we're dealing with 50%. Is it the status epilepticus that has killed these patients? Probably not. It does play a role, but likely these are really sick brains to begin with, and this is just adding another layer on top of this sickness. So again, nothing to be dealt with lightly. And again, it's like sepsis, aggressive treatment at the beginning, aggressive if you can, because the long-term sequelae and the mortality is quite high. If we look at refractory status epilepticus now, again, adult literature, 23 to 61%, high morbidity as well. And in kids, we're talking about new deficits coming up. So again, with all of those, convulsive, non-convulsive, and refractory, we're talking about a high percentage of mortality and a high percentage of morbidity where people don't return back to their baseline. So your diagnostic workup will help, obviously, because what we want to do is categorize the patient, because it's one thing to slam these kids with anti-epileptic, but the other thing is if we don't address what's fueling it, we may prolong the status that's happening. So again, in all patients, all CNS patients, well, all patients in summation, but particularly with CNS, you must do a glucose. A glucose is as important as a heart rate. Monitoring vital signs. A CT scan is not something that's going to be in the transport environment. But a lot of these things that we can do a blood glucose, we can do a CBC in most places that we go to, we can do a calcium and extended lights, a basic metabolic panel I probably wouldn't include in transport. You're not going to be doing EEG. But you can do a lot of things. You can look at the things that you can reverse with magnesium, with glucose, with electrolytes. And so I think that's the important message for you. The other things that happen here, the LP, the MRI, the CT, are all things that are going to be done here, obviously. Things, the history that you can get, the toxicology panel. Did this kid get into mom and dad's tricyclic antidepressants, sympathomimetics, etc.? So those are things to help, because if you don't get this history, we might not be going down that pathway. We might not think that has occurred. But definitely glucose, definitely extended lights, and definitely a very good history, so that when they come here, we may be able to investigate that in further details. And I bring this up here as well. There's a few centers that you'll go to, Boundary Trails, Brandon, where they may do a CT. And really the only thing you want to look at CT is there a bleed or not? And I didn't go over that. A CT is bright red on blood. And likely if they have CT capabilities, they'll have a radiologist that will be able to read it as well. I wouldn't do an LP. Leave the LP for us. I have strong opinions on doing LP in critically ill patients, particularly neurocritical care. There's a possibility that you can get this patient a lot sicker first, so leave this up to us. If you're going to start antibiotics, I don't care. Start antibiotics, leave the LP for us later.
If they've done a CT, do we try and get it pushed through to here if possible?
Absolutely. So there's two ways that you can get a copy on the hard copy, or I know that the health departments are trying to get together and electronically do it. But absolutely, if you can do that, that would help. Absolutely.
Or else bring a hard copy.
Or bring a hard copy. And typically they'll have a disc. Yeah?
No, actually, that was one question. The other question, do you want us to take time to do a CT if we're on transport? And
I think that's a discussion with medical control.
Okay.
In most instances, a kid that comes in status epilepticus, unless there's focality, doesn't need a CT. If you have a history, let's say, of toxicology, no CT. If I just drop here and I start moving my right arm and my right leg, CT me please, because the bleed is high on the differential. But based on the semiology and based on the history, Either absolutely this kid needs a CT or CT is a very low priority. So
okay.
I can't answer that with a blanket statement.
Okay, man, thank you.
Yeah.
Thank you.
That's why semiology is really important. If there was a history of focality that led to a generalized seizure, and a generalized meaning the entire body, that focality is important because it's coming from one part of the brain, and it's very possible that there's a bleed. But if that kid started with a generalized seizure, then a bleed is less likely.
Great, for the LP, so that's a skill we're not going to learn.
It's not a skill you're going to learn. No.
Can the referring center do that?
I prefer not. I prefer not.
Wait.
If it's going to be a stable kid that's ruling out sepsis, yes. But in this setting, I would not. No.
We had a kid that the LP did the meds that herniated.
That's what I was just gonna say.
Yeah.
Your risk of herniation.
Yeah.
And often when they do an LP, some kids, they like to look at opening
And
pressures.
just-
Yeah.
Sugar joke, they do that.
Who needs this?
No herniated.
They
like
should.
died.
Yes.
Oh, like,
Yeah.
Okay.
Herniated.
yeah, okay, yeah, we understand.
So let's talk about
And he just
treatment
had-
and what's going to happen.
I went off of this, but they don't fix it.
Important thing with seizures is most seizures don't cause hypoxemia unless they're prolonged, and most seizures will not cause a significant hypercarbia until they're prolonged. And so I was always taught my neurocritical when they intubated these patients, most of the time, if they can protect their airway, they're going to be okay from an oxygenation and ventilation perspective. The reason why they become apneic and a lot of reasons why you need to intubate them is because you have to slam them with so many anti-epileptics that they can no longer protect their airway. But in most instances, if you arrive at the bed and somebody's seizing, you can support their airway, but having a more stable airway is lower on